Hi, everyone. Welcome back to Paging America, where we explore the power, profit, and politics shaping American healthcare and what you can do about it. I'm your host, Miles Baker, along with Dr. Rob Davidson. A quick note about today's show before we get started. We're going to be discussing the tragic case of Adriana Smith in Georgia. The show is going to use some medical terms intended for a medical audience that could seem jarring or insensitive to a lay person. If that isn't your cup of tea or you have kids in the car, feel free to join us on the next one. We'll get started. We're extremely excited today. Our guest today is Dr. Mimi Zieman. She is a physician, author, playwright, and speaker. In addition to Tap Dancing on Everest, which was selected as the best memoir of 2024 by the American Writing Awards, she has co-written 17 editions of the medical guide Managing Contraception. Her recent play, The Post-Row Monologues, has been performed in multiple cities, and other writings have appeared in USA Today, Newsweek, Salon, and many other publications. Her Substack newsletter is Medicine and Mountains and More. Dr. Mimi Zieman, thank you so much for joining us.
Thanks for having me.
Yeah, welcome to the pod. So we're going to get right into it. Today we're going to be discussing this case in Georgia. You're a practicing OBGYN in Georgia, and how, maybe to lay the groundwork, how's the world changed in your practice or in sort of the way that you do your job? How has it changed in a post-Roe environment in Georgia?
Yeah, I consider post-Roe environment sort of a moral injury to physicians. We are trained to provide evidence-based care, the best care for our patients, to have ethical principles guide us, like patient autonomy, justice, not doing harm, beneficence, and having the government hamstring us with their opinions as to how we should practice is terrible.
That probably brings us to what's happening and why Georgia's in the news today. The medical case, I'm going to give a little bit of background so folks who have not been following this as closely as everyone here can stay up to date on the conversation. So the medical case involving Adriana Smith, a nurse pronounced brain dead in February 19th, was 9 weeks pregnant, remains on life support. The case is reigniting political and legal debate over Georgia's abortion law, with the family of 30-year-old Adriana Smith claiming that they were unable to make decisions about her care due to the state's Life Act, commonly known as the Heartbeat Law. Democratic state lawmakers have put out statements calling the situation barbaric. Emory Healthcare and Atlanta Hospital System put out a statement saying that it uses consensus from clinical experts, medical literature, and legal guidance to support our providers as they make individualized treatment recommendations in compliance with Georgia's state abortion laws. Some critics of the criticism say Georgia's Code 31329, part of the state's Advanced Directive for Healthcare Act, may be the applicable statute. And that statute restricts doctors from withdrawing life support from a pregnant patient unless the fetus is non-viable and the patient had a written directive explicitly requesting such an action. But Dr. Zieman, we can read the articles, but we aren't in Georgia. What is your take on the case, and what are you hearing among friends and colleagues?
I think most people agree this case is incredibly tragic, especially the fact that the patient's mother went out to the news at this point saying that she's suffering every time she sees her daughter in this condition. And she came out and said she doesn't know what the family would have decided, but that she's speaking out because they didn't have a choice. So I think, most people agree the patient or her family should be having the choice. But that's why I'm not sure we're hearing everything. To be honest, what I'm hearing on the ground in Georgia is that what's been reported in the news may not be all the facts. And that makes sense to me as a physician, because it's not adding up that this is the care that, as your statement that Emory put out, would support, right? I don't know. Yeah. Rob, what do you think? It doesn't completely add up. We've seen the mother go to the news, but I haven't seen anything of the patient's partner. Have you in the news?
Right. Yeah, no. And I just had a case of an individual who was on life support and their brother was their designated proxy decision maker. And all states are a little different, right? Some people have advanced directives. I hope everyone who's listening does, and we all should have advanced directives naming the person we want to make decisions for us. And what that really says is, I am unable to make medical decisions. This person acts as me and has all of the legal and binding, ability to make those decisions. And this patient's brother, told us what they wanted, and we were fully resuscitating this person. And at a point in the care of this individual who was on a ventilator, who was on multiple vasoactive drugs to support their blood pressure, he said, if his heart stops at this point, he would not want CPR. He would not want to be shocked. And about 12 hours later, he got transferred to a tertiary care facility, and they decided to withdraw support, and he passed about an hour or so later, according to what his family said his wishes would be. And so in this case, this hospital system is saying, to be in compliance with Georgia's abortion laws, right? And perhaps there's another piece, the code that Miles noted, if the fetus is non-viable. Now, we would all say a 9-week embryo would be non-viable when this diagnosis of brain death occurred. So within the confines of that particular statute, one would say that they would be able to withdraw support.
Yeah, even the state's conservative attorney general said withdrawing care and a 9-week fetus dying would not constitute abortion. So it would not be in violation of the state's abortion law. So I don't think we have all the facts. I did read something really interesting that Arthur Kaplan wrote. He's a preeminent bioethicist. Keeping the woman alive at this point artificially is literally experimentation, and nobody would be forced to experiment on someone in this way. That would be completely unethical to force physicians or other people to keep her on life support in the way that she is.
Yeah, and we have to be clear about definitions here. We say brain death, but in every state and the District of Columbia, and this is the part that, it gets a bit technical and gruesome, but brain death is death. This individual is legally dead, and they have a ventilator supporting getting oxygen into their blood. They probably have drugs supporting their blood pressure, certainly nutrition, either through a tube in their stomach or through their IV or both. So this is actually someone who has been declared dead, back in February. And again, they very much say in their statement, in compliance with Georgia's abortion laws. So whatever the attorney general is saying after the fact, now we're dealing with, someone who's 20 some weeks into this, definitely in a viable state. And I think after the fact, they can say that to try to avoid the criticism. But this is what, at least my take, and you tell us in Georgia, in a place that has a heartbeat law, post-Roe, the post-Dobbs decision by the Supreme Court, it's this murky morass of what is or isn't legal, what is medical. Does that feel right, that there's just a lot of unknowns, and that's the problem?
And I think that's the whole point. Is that we keep getting into these problems in all the states because of the way that individuals are interpreting these murky laws, which is really why they shouldn't exist. People should be able to always offer the best medical care in that instant for that patient without worrying about these laws, being fined, being arrested, going to jail, all the other things.
Yeah, we had a period in Michigan after the fall of Roe that the draconian, 1849, I believe, abortion ban was maybe briefly in effect, but then our governor stepped in, said it wouldn't be prosecuted, and our attorney general said that. But then we had individual prosecutors from certain counties, including the one adjacent to where I am, where a big hospital system, saying, well, no, this is the law. We would prosecute. So no, how can you take a state attorney general and take their word if there could be a prosecutor who has decided, well, in my interpretation, this is violating the law? We all practice medicine with the risk of malpractice, right? Civil cases can come. Many have had them, most probably in their careers. Certainly OB is a high litigation field, and intensive care medicine where this patient is currently being cared for. We prepare for that. We know that. We have insurance for that, right? We practice quality medicine, and then we don't go into med school and come out prepared to face criminal charges for providing good medicine. Do you feel that, or is that kind of the sense in a state like Georgia where they have this heartbeat law, the criminality of providing quality care?
Yes, absolutely. And there are other examples of that. So for example, our heartbeat bill, prohibits abortion after seeing fetal cardiac activity, which we know is not actually cardiac activity, around 6 weeks. And yet we see patients from Tennessee and neighboring states who allow 0 abortions. So the fact that we can have some early abortion, we still have patients travel. To your point, Alabama's attorney general threatened anyone helping a patient go to another state that they could be prosecuted. And what that led to is the Planned Parenthood in Georgia, which covers Alabama, it's called Planned Parenthood Southeast, so it's Mississippi, Alabama, and Georgia, was not allowing Alabama patients to be seen in Georgia just because of that threat Tennessee patients could be seen. And so to your point, it's so murky. There's so much threat. There was a survey, really interesting survey done in North Carolina by a physician in North Carolina on OBGYNs in red states, documenting the stress they feel, the fact that several of them plan to leave the state or move to another state. So, and what I think a lot of people in the population don't understand is that when that happens, they're going to have less care for their cancer, their fibroids, their heavy bleeding, all the routine OBGYN condition. Maybe that will wake them up when they go to the voting booth because they have to see how it affects them personally.
Dr. Zieman, that story about Alabama reminded me of a quote an activist told me while I was organizing in Atlanta. They said, "You're in the Bible Belt. Welcome to the Bible Belt. But just remember, Alabama's the buckle."
Jeez.
That story about Alabama we're starting to see echoes of that in the outlines of the new mifepristone fight, where states are saber rattling around reaching across state lines for enforcement. Whether they're reaching all the way up to New York or sort of over to California. I'm wondering how does that top of mind for physicians as they're practicing? Is that part of the conversation, or is this too new of a conversation? This is too new of a phenomenon where we're threatening cross-border enforcement?
Well, I think if you're an OBGYN and you're aware of this and you're seeing patients, it is top of mind. It led me to write one of my op-eds was literally the day I realized when I pick up a patient's chart, the first thing I look at is her address. When have we ever been trained to think about a patient's address and wonder how that's going to influence our care? And I said, this is so wrong. I'm going to write a piece about this. That was in USA Today. And, it directly was in response to Trump saying, this is the greatest thing that we're moving to the states.
Yeah. Yeah.
Every state can decide what they want to do. No, it's actually fracturing healthcare.
But in reference to your point, looking at the address and across state lines and Trump saying, beautiful, leave it to the states, that was their attempt to deflect any responsibility they have in these abortion bans. Like, saying, well, these aren't national abortion bans. These are the states. Well, the problem is this appointing these judges to the Supreme Court. That is what allowed this to become a state's issue. And then it reaches across all state lines, as you're telling us. I mean, I think there's a case now, a New York doctor being sued by Texas, correct? For providing abortion pills for people who live in Texas. This seems very problematic to me. And it's fine for us as advocates, and you and I are both physicians and we practice medicine, to say, well, just do the right medicine, to hell with these prosecutors and other jurisdictions trying to come after you. I think it's probably easy to say in the abstract, on a podcast, when you're looking at your livelihood, not just your livelihood, your freedom, your ability to be with your family and not be incarcerated, being on the line. I don't know that any of us should ask anybody else to risk being prosecuted, being thrown in jail to practice what we all know is good medicine. They have done this, right? The leaving it to the states has created this, repealing Roe has created this. And it's created this mess currently going on down in Georgia with Adriana Smith and her family being completely locked out of any decision-making about her care. And frankly, I mean, maybe you can speak to this. I think there's been reporting the likelihood that that when this child is born, that they survive, right? Or they lead a healthy life or have normal. I mean, I think I've read reports, and again, it's all kind of tough to get all the info, that there's a lot of fluid on the brain. Having an abnormal appearing brain and an ultrasound in utero doesn't portend a great outcome as far as I know. I'm just an ER doc. Please, you're an OB. Let us know what that means to you.
No, it's just awful that they, from what the reports are saying, that they've forced this on the family, if that's the case. And apparently the family has to pay for the medical bills. There's a GoFundMe for the family, and that they would be obviously raising, if this fetus survives, a child with deficits, potentially terrible deficits, because again, we're experimenting on this brain dead woman, which some people are referring, have some other words for. And the other thing to think about is doing a C-section. Like, who is authorizing that? We're not allowed to remove organs from somebody who is brain dead that did not authorize organ transplantation. So how are we allowed to do a C-section on this woman? Who is authorizing it? It's just so many ethical questions.
Right.
But again, I'll say I don't think we have all the facts.
Yeah. Well, again, this just highlights the mess that was created by appointing these Supreme Court justices and by them taking out a 50-year 49-year precedent of Roe v. Wade that we all practice under and expected to practice under, right? That was law of the land.
and which
Let me-
several of them said they wouldn't do, that they
Right.
believed in precedent.
Yeah.
Yeah. Well, let me shift gears. For a person who is a non-doctor and hasn't necessarily studied medical ethics, it certainly seems like an extraordinary amount of like cascading difficult decisions that's put physicians and everyone involved in the healthcare system in a precarious position. Maybe switching gears a little bit, this is one, as I understand it, has dominated the news in Georgia in local outlets. We're looking through even like the Atlanta television, the newspapers. It's also rocketed across TikTok, Instagram. It is sort of populated the reels and the and the phones of folks who've been following it, and it's created like almost a cottage industry of content commenting on it. With that amount of, even if the facts are not fully known on how decisions are being made, with that amount of content and that amount of sort of booming communication around this, do we think there's ramifications for the politics of abortion or the politics of reproductive rights in Georgia? We know that the state legislature is going to be up this next year. We also know that there's an incredibly important governor's race coming up in a year and a half. Doctor, I'd love your take on what you think this might do
that's
to
so
the landscape.
interesting, because when our abortion law was passed in 2019, I spent a lot of time down in the legislature trying to inform the legislators of what was going to happen, along with many other people. I mean, when that bill was debated in committee, there were about 100 of us who testified to oppose the bill and present every possible consequence. So those legislators were informed about every horrible thing that could happen, which have now happened. We've seen deaths. We've seen cases like this, right? So they knew. So to your point, now they know even more, and something else. Is it going to change them? Now, that bill actually passed by only one vote.
Really?
So it kind of depends on the makeup of the legislature when other abortion-related issues will be discussed. I do want to add the other, I mentioned moral injury, and the other ethical principle is justice, right? Which we haven't talked about. It's unjust for one state to have these laws and another state to have another. That your care is based on a zip code. It's unjust that women of color are suffering so much more than other women. They can't access the care. This is a woman of color, Adriana Smith. So were the two women reported last year who died as a consequence of the Georgia abortion law, and probably many more that we don't know about. So will that influence the legislators? Maybe.
Yeah. And I think it's up to advocates, right, to make sure people understand when they're going to vote. Like these people voted for this, right? This is, it passed by one vote, but it did pass. And so I think it seems critically important to make sure that people going out there to vote understand.
Absolutely. And when they do population surveys, most people do not want the government in the exam room and do not support these bans. And to your point, Rob, are they truly informed when they go to the voting booth of the consequences of their vote and how it affects women generally and their families and, themselves?
It does feel like a law that is on the books for a Georgia that no longer exists. For like, as Georgia has changed and as Georgia has become more diverse and as Georgia has become a state that's got a lot going on and demographically and in terms of their politics and in terms of their values, it does feel like a little, it all feels like an anachronism in any state where we have a heartbeat law. But in Georgia in particular, to me, it seems like it's something that's from an extremely different era. And it's in stark relief to what's happening in other states that look like Georgia.
Yeah. And we as advocates, we're hoping the pendulum switches, right? When people see all these horrible consequences, they'll rally for more, medical freedoms, but it's a little unpredictable.
Yeah. I think it's fascinating what it could mean for the governor's race. We saw in the last election that people said that abortion issue, whether it was in battleground states or across the country, it was like less salient. It was less top of mind. People have talked about costs and people have talked about all these other things, but it was still important for an extraordinary amount of people when they went into the ballot box. And I imagine that this raises the salience, particularly in Georgia, but possibly across the whole region.
Well, to your point, Miles, the states where people are allowed to vote for abortion access overwhelmingly have voted for abortion access, right? And I believe that if Georgia had that opportunity, our state would as well. Okay, they would, if the people could vote, would reverse this ban. We are a state where you cannot get a referendum on the ballot unless the majority of the legislature and the governor would sign off on it, which we have a Republican House, Senate, and governor right now.
Let me ask so we're talking about the politics of the governor and the legislature, but there's other ways where you could conceive of this having ripple effects. We know that the sort of medical societies are in every state take positions or abstain from taking positions when there's big public discussions or policy discussions on topics like this. What have we been hearing from the medical trade associations or the medical society in Georgia? Have they been really out front on this?
Well, society did oppose this abortion ban in 2019.
Okay.
And back to when I was testifying there, one of the state senators asked me, what do the major medical societies say about this? And I was able to say the major medical societies all oppose abortion bans, oppose the intrusion of government between patients and physicians, including the American Medical Association, right? The National OBGYN, PEDS, Family Practice Association, all of them. It didn't influence the legislators knowing that. And what's really gotten them rallied up is the IVF controversy. Yeah. Because that is easier to get behind than abortion access. So I think they've been more vocal about that.
Yeah. That's so frustrating to me because at least we talk to thousands of doctors across the country at our day jobs at the Committee to Protect Healthcare, and we don't find a lot of people who are anti-choice in the medical field. I get worried that some of the medical societies or some of the trade associations are over-indexing on their sort of anti-choice members, and that's calibrating how public their response is or the sort of position they'll take and how forcefully they'll push. It's a little frustrating to watch from the outside.
What happens in a state like what happens in a state like Georgia is physicians are afraid to go on record as being pro-choice because they think it will influence the patients that come to see them or decide not to come to see them. And that's always been a real stronghold.
Yeah. That makes sense. Dr. Rob, I had one more question for you on in a state that doesn't have a heartbeat law. Yeah. I mean, this is a little bit of an edge case. This is a complicated question on medical ethics and heartbreaking. How would this get handled in a hospital system traditionally in a place that did not have a heartbeat law?
Yeah. I mean, one would imagine, right? I can sort of anticipate how my hospital or how I would as a physician in my hospital and how I understand how these decisions are made is you would go to the family and say, listen, your loved one has had this devastating injury, this brain injury that has now left them, in this case now as an ER doc, we don't declare people brain dead. That requires multiple neurologic exams and testing and all that. But if they got to this point and say it was just someone who we said this person is in a situation where they're unlikely to survive without massive medical intervention. And we would go to the person either designated by the patient as their decision maker, usually a spouse or parent, child, somebody. Or in the state, it's basically their direct family, which can be problematic because there's multiple family members sometimes who might not have the same viewpoint. But you would try to gather consensus of those family members present, and you would make the decision for the individual based on what they are telling you. And I always tell the families, this is not what you want. This is what they would want, right? So again, another plug that everyone should have advanced directives, name that person and talk to that person. These kind of situations would be quite rare, but now I think probably need to come up. But that decision then would be made by the family, right? And I think in the case of a pregnant individual, like in the case of a non-pregnant individual, if someone's declared brain dead, you would let the family know, listen, they are legally dead. We will have to withdraw support. And you might give them some time for people to come from out of town to pay their last respects, what have you. In the case of a pregnant individual where there is this potential for life, I imagine they would get the ethics committee involved and discuss kind of the realities of keeping this person on life support. And if the family wished to do so, I would imagine hospitals would comply with those wishes. The state would not have a say in it. And that's the important thing, right? Like we have a hospital, doctors, patients, and their families. These are the people who should be involved in these decisions. We've been saying that all along. If someone chooses to not have an abortion or have an abortion, I don't care, right? That's what pro-choice is all about, right? They get to choose. So yeah, fortunately, I do live in a blue/purple state, but in a state state without a heartbeat law here in Michigan. And yeah, not blue anymore. And so, yeah, we won't have to suffer the state making these calls. I feel for people who are down in the Bible Belt or other places where they do exist. And it makes it a lot harder to do good medicine.
Well, okay. That was a heavy conversation. Maybe we can move on. We have a lot of action happening at the federal level. We didn't get a chance to cover some of the aspects of RFK's interview at the Help Committee that happened 2 weeks ago. So we want to talk about that. In the Senate Help Committee at Health and Human Services 2026 budget review, Josh Hawley seemed interested in continuing his crusade against mifepristone. I'm wondering if we could throw to that clip now.
Yeah, so bear with us. A little over a minute clip here, but we're going to listen to his questioning of RFK Jr. And then on the other side, I'd love to talk to you, Dr. Zieman, about your thoughts.
There's been a major study by the Ethics and Public Policy Center of 865,727 prescribed cases of mifepristone abortions, chemical abortions, between 2017 and 2023. Have you seen this study? Are you familiar with this? Do you know?
Yes, I am.
You will remember then that this data shows the biggest study on mifepristone done, I think, ever, and it showed that nearly 11% of women experience very serious adverse health effects, to include sepsis, hemorrhaging, infection, of course, emergency room visits. My question to you is this. You previously testified at the committee that you would do a top-to-bottom review of mifepristone. Continue to stand by that, and don't you think that this new data shows that the need to do a review is in fact very pressing?
It's alarming, and clearly it indicates that at very least the label should be changed. I've asked Marty McCary, who's the director of FDA, to do a complete review and to report back.
Dr. Zieman, what are your thoughts on Senator Hawley sort of getting this assurance from RFK Jr. that they will re-review mifepristone based on this, quote, study from the Ethics and Public Policy Center about mifepristone?
Well, this has been their goal all along, to try to limit mifepristone access, because mifepristone is saving lives, actually. Yeah. Mifepristone is why we don't have back alley abortions.
Yeah.
We were not hearing about those sorts of things as much, right?
Right.
And it's the majority of abortions nowadays, 63%.
Okay.
Mifepristone was approved in France in 1988, the U.S. in 2000. We have a lot of data on mifepristone, hundreds of peer-reviewed studies. Bringing up this study done, they're calling it a study, by a right-wing think tank at this point in time. You're going to believe that is science that's going to negate decades of science proving this medicine is safe and effective? No, I don't think so. It's not peer-reviewed. It's not published in a peer-reviewed journal yet. That's not a reason for the FDA to reconsider access to a safe, effective medicine.
And just a little background on this group at the Ethics and Public Policy Center. I mean, it's a kind of very right-wing evangelical group, very much opposed to anti-choice group who, they call this a study. It's an insurance review from 2017 to 2023, 865,000 instances where mifepristone was prescribed. Now, they did not confirm that everyone took the mifepristone, just that it was prescribed because it was an insurance review. And then they looked for potential complications listed under coding for insurance purposes: sepsis, infection, transfusion, hemorrhage. They cite a number of 11% had serious complications, he calls them. Well, 5% of those were an ER visit related to an abortion. I had someone come in to a week after mifepristone and they were having some bleeding. It wasn't severe. Their blood count was normal. Their blood pressure and heart rate were normal. I talked to the OB. They followed up in the clinic, and that abortion actually completed itself. It just took a little longer than this person had anticipated. They actually said to the nurse, I was a little worried because I work in a very rural kind of red area. She was worried about coming in because she thought she might be judged about her use of mifepristone for a medication abortion. We assured her that, we were just here to practice medicine and had no judgment over her choices that were completely legal and ethical. And this person did not suffer any ill effects. That would have been categorized as one of these serious complications. They report repeated abortions. So it's a need for a surgical abortion, which happened in just under 3% of these individuals, as a serious adverse event, whereby within the FDA's own literature and the drug pamphlet for mifepristone, it says around 3% might need to have a surgical or a procedure abortion because the mifepristone just might not work. They cite hemorrhage in 3.3%, but that's just, again, an insurance code. If someone has heavy bleeding, even heavy menstrual bleeding, someone might call that hemorrhage and it gets pulled out. So first, it's just total BS that Hawley is citing these as major adverse events, right? They do cite sepsis 0.1%. That's a little lower than the FDA cites, 0.15%, 1 in 1,000. So it's totally disingenuous, not an actual study. And the fact that our HHS secretary is saying, yes, based on this kind of right-wing non-study that you, Senator Hawley, are citing, we're going to do another review of this. This just is the whole ballgame of RFK and the anti-science crusade.
This seems like a bad version of a normal playbook that the right runs all the time, where they have one of their think tanks set up. Some of those think tanks are more credible than others. This one seems like a particularly not credible think tank, where they commission some study with juiced up numbers, or they sort of cherry pick data and they release that study so someone has something to cite, so they can pretend that they have an authority to do the thing that they were otherwise already doing. Hawley's been talking about going after mifepristone forever. This is a political prop. And I think calling it anything more than a political prop is giving it a little bit too much credence. And it's a well-treaded tactic that the right rolls out.
Yeah.
Doesn't seem like it's particularly special, but the ramifications seem big.
Yeah. We need a term for this, right? Money laundering is how you take dirty money and get it into the population. This is study laundering. It really is. Because the problem is you have credible news outlets now saying Josh Hawley cites study on, and so when people hear that term study, you think, oh, a study, someone did research, someone had this verified, and they don't talk anything about what those, I talked for a minute or two, maybe I talk longer, I tend to talk a lot, but a minute or two to actually poke holes in what this quote study that he's citing is. The problem is by the third person that references what Hawley was talking about, it has now been accepted as a study, and that percent has been accepted as a percent, and disingenuous people like RFK Jr., who are just out to do the bidding of all these folks to keep their job, whatever he truly believes, I have no idea, but he's willing to do their bidding. That seems like a problem. I don't know, Dr. Zieman, if you have any thoughts as a practicing physician for several decades, the damages can really do to our patients and actual studies.
To your point, the damage it could do is somebody hearing that and believing it and then not going to take, have a medication abortion if that's what they wanted, right? When we know that it's a safe, effective treatment. Yeah, a study that hasn't been published in a peer-reviewed journal is not a study.
No.
Right?
Yeah.
Medically speaking. And they've been trying, they tried this last year when they brought an action to get mifepristone off the market by people who were not directly prescribing it, saying that they were being harmed because they're taking care of all these complications. And the Supreme Court said, no, you don't have standing to bring this argument against mifepristone. You are not actually harmed by having this medication available. But that's part of it. They've been trying for years just to limit access to mifepristone.
Yeah.
Dr. Zieman, you've been doing reproductive rights advocacy a lot longer, I think, than Dr. Rob and I, and have probably been watching the opposition longer than Dr. Rob and I. What are you worried about? Where are they going with this? Where is this headed?
It has to do with who the judges are that are making decisions, right? Because most of our recourse is in the courts. And so it really depends on what judges are sitting there and making decisions. And
I think the other worry for me is that the FDA puts some kind of a black box warning. And if for people who aren't aware, maybe Miles, you're not, black box warnings, they're for drugs that are authorized, they're approved, but they give a particular, risk that we have to be aware of. And in many ways, black box warnings dissuade. It works. It has for us and in the ER for certain drugs for nausea and vomiting because of certain effects on the heart rhythm. Even though they're very similar to others, the FDA just sort of came out with a black box warning for some drugs, and they really curb the prescribing of those particular drugs. So that's another concern. It could make doctors who otherwise know, wait a minute, like this is actually safe. This is safer than procedure abortion by far. It's accessible. It's highly effective. It's much less, cost effective. But boy, there's this black box warning. If they have a complication, I could really be at risk for this. Am I willing to take that risk? So not even dissuading patients from doing it, but dissuading doctors from prescribing prescribing it, simply because whoever's at the FDA isn't looking at real science. They're kind of looking at the Hawley-inspired, quote, studies that are being pumped out by right-wing think tanks. I think that, yeah, the ripple effects of this are really
Well,
extreme. I think they're trying with vaccines, like that's their play in this as well.
to your point, Rob, if they cited this in the pamphlet of mifepristone versus the peer-reviewed studies that say serious adverse events are 0.3%, and instead decide to cite this, which was, what did you say, 11%?
11.
Right? That's a huge difference.
Huge.
All right. I think that might be a good place to wrap up the two very heavy conversations we've had today. I would like to propose a palate cleanser. Dr. Zieman, you have written a book called Tap Dancing on Everest. It is an award-winning book. People love this book. I wondered if you could tell us a little bit about what your inspiration was to write this book and what you wanted people to take away from it.
Thank you. Yes, it came out about a year ago. It's a coming-of-age memoir connecting being the daughter of refugees raised in New York City with becoming the doctor and only woman on a groundbreaking Everest climb in Tibet when I was a 25-year-old medical student. So I say serving in that role as a student was like my Everest. And, I wrote it so that people could see that, they're capable of a lot more than they think they are. Like in the book, I'm very honest about my self-doubts in taking on this big responsibility. And, we're often capable of a lot more than we think we are. But, we say we're not good enough, prepared enough, qualified enough. It's an adventure story. It's got a lot of feminist threads, the interesting medicine that I did on the mountain, and, adventure.
That's great.
Full disclosure, I haven't read it. I read the jacket, and we just kind of booked this interview a couple of days ago, but I did just buy it. It's going to be at my house tomorrow. So I think these, it sounds like a great story that probably reads like a novel, even though it's real life. And that to me is the best because, especially getting to know someone.
The cool thing about it is, unfortunately, we did, this is not cool, but we did experience a lot of trauma on the mountain. But what I was going to say is I had to step up into finding my voice to advocate for the injured climbers. And so that's how I bridge it to my advocacy today, that, I learned what I learned on the mountain that would inform my lifelong mission to advocate for other women's self-determination, having had the privilege to achieve my own on Everest. So that's how I kind of bridge that. And also, my father was a Holocaust survivor, the only survivor in his entire family. Everyone was killed. And he always used his voice and spoke out for peace and civil rights and other things. So he was my role model to always use my voice. And I feel that as physicians, we have knowledge that we need to bring out into the public, and all use our voices in our specific ways. So for me, turning to writing at this late part of my life is just another way to elevate women's stories and advocate for women, whether it's through my own memoir or writing op-eds or writing the play that I did, the post-Roe monologues. And so, I also hope to have other people use their voices, basically.
That is so inspiring. And I will say I am a latecomer to the advocacy world. I was a practicing emergency physician for 20 years, just sort of living my life, raising a family and getting involved where I could, and then really kind of diving into advocacy in the last 5 years since my late fees. And I think you're right. I think it's great that you have decided, you described as a late part of your career, to really dive into writing and being more of a public advocate, although it sounds like you've been doing advocacy for quite a long time. You're a latecomer to that. But it's never too late. And I think not every person can be an advocate. Not every physician feels comfortable. And we certainly know, but we have met along the way a lot of folks, including yourself, who do. And thank God for it, because we need that. Our patients need that to advocate beyond the bedside. And it's inspiring to hear.
Well, especially now in our world of disinformation, right? We want to propagate real information.
Absolutely. Absolutely. Well, thank you for that. And go ahead, Miles.
Well, I was just going to say, it sounds like Tap Dancing on Everest might be required reading if you're thinking about getting into advocacy. I think that might be a good place to end it, unless anyone has anything else to add.
No, it sounds great.
Okay. Dr. Zieman, thank you so much for joining us today. This is an informative conversation, a little bit of a hard conversation, but an important one for people to hear around the country, and particularly doctors who are tuning in. So thank you so much for your time. And
thank you for having me.
All right. Well, that was a great interview with Dr. Zieman. I think it was incredibly important to hear a perspective of someone who's sort of following this closely in Georgia. What do you think, Rob?
Yeah, I thought I love getting your perspective from on the ground in Georgia. certainly her perspective as an OBGYN in that state who's been practicing for a while, the things about the cross-state dynamics that
Scary.
I don't think
Scary
either of us
stuff.
really appreciated to the extent that it is happening on the ground. Also her perspective on mifepristone as a longtime advocate in her own right. And then just her last piece, like, you know, it's always interesting to meet people who have done really interesting things in life and have these
Good
bios
vibes,
that are a bit intimidating, but then, you know, they're
Yeah.
just kind of regular folks kind of doing the work that we all aspire to do. So that was great. But yeah, I would love it. Love to have more conversations with her. But if you would like to, I'd love to have you read us out.
Today's episode was written by Chris Savage, Dr. Rob Davidson, and me, Miles Baker. It was produced by Amelia Dillon Schneider, Aslan Ibrahim, and Joel Bryson. Music by Annette Somerset at Dune Flower Productions. If you enjoyed today's show, please subscribe and leave us a rating on YouTube, Spotify, Apple Podcasts, or wherever you listen. Your support helps others discover the podcast. Physicians, your voice matters. Join the fight for better American healthcare by becoming a member of the Committee to Protect Healthcare. Visit committeetoprotect.org to learn more. And we love your feedback as always, particularly on today's show. We covered some hard topics. Please send your comments and suggestions to feedback@pagingamerica.org. We'd love to hear from you. We'll read everything that comes in, and we might take it into account. So thank you so much for listening, and we'll see you next time.